So we're going to be talking about post-operative vision loss after spine surgery, and this is a non-ocular surgery. The ways you can lose your vision after spine surgery in neuro-op are central retinal artery occlusion, anterior ischemic optic neuropathy, or the retrobulbar form, posterior ischemic optic neuropathy. In CRAO, there'll be a cherry red spot. This one is usually from the anesthesia, from compression, because they're in the face down position. The little donut that they put their head in is moved over a little bit. It presses on the eye, and that means there are two factors that we need to be considering when we have the perfusion pressure, which is the MAP or the IOP. So any rise in the IOP or any drop in the MAP will drop the perfusion pressure. So this one here, central retinal artery occlusion, is from compression of the eye leading to a rise in IOP, and that's what causes the central retinal artery occlusion. These two here are about MAP and IOP. And so the drop in the MAP is related to surgical factors. You're having anemia, you're having surgery, you're having anesthesia. And so we need anesthesia to monitor patients who have pre-existing conditions like hypertension, male, gender, obesity, smoking, the usual vasculopathic risk factors that patients bring to the table. And that means you might have an intra-arterial line on this patient right here. And the IOP is from the head down position. So in spine surgery, they're in the head down position. Sometimes they have a frame that's pushing the back up so they can operate on the back. That thing's called the Wilson frame. And a table that puts them into the Trendelenburg position. Those raise intraocular pressure because there's impaired venous return, and that causes an increase in the IOP. So the countermeasures for this post-operative vision loss, some of the factors you cannot change because they're predisposing risk factors. But these predisposing risk factors are what should alert you that you might need to make intraoperative or post-operative adjustments on this patient. And those are male gender and obese, and then the vasculopathic risk factors, hypertension, hyperlipidemia, diabetes, smoking, the usual suspects. Because you can't really do anything about this, you can optimize the risk factors, but you can't change some of the risk factors. So you need to be aware of the risks associated with the Wilson frame and the Trendelenburg, and we normally recommend that the head be at or above the level of the heart to avoid this venous return problem. And we're going to monitor the mean arterial pressure. We're going to transfuse the patient if they need blood, and mostly that means being ready with autologous blood if it's an elective procedure. The duration of the procedure also matters. So if it's a multi-level complex fusion, we would try and stage that procedure to reduce the surgical time below about 4 to 5 hours. If it's going to be a 10-hour case, just make it 2 5-hour cases. And spine surgery is the most common non-ocular surgery to cause post-operative vision loss. The second most common is cardiac surgery, but any surgery can do it. The unique features of the spine surgery are the head positioning, the face down prone positioning, the blood loss, and the hypotension are common to all surgeries. And we got to worry about IOP because of the face down, both for CRAO and for perfusion pressure of the eye. And if we're going to replace the anemia, transfuse them. And if you're talking about fluid replacement, we prefer colloid over crystalloid to hold the intravascular volume. And most importantly, in the pre-op, recognize the predisposing risk factor and perform an appropriate and documented informed consent, including the possibility of post-operative vision loss.